Good afternoon. APT decided to do community forums to connect some dots between clinical practice, the research that they're heavily engaged in, and folks with lived experience and the social agency side of things. So they've occurred this past year. In the past 12 months, they've been doing forums on overdose prevention and training for Narcan, topics like the overlap between hepatitis C and substance use disorder, and the proactive way that the APT Foundation is making sure people get screening and treatment for that. Chronic pain has been another topic. And today's topic is housing status and opioid use disorder. And we brought in Marina Gaeta Gazzola, who has she graduated from Yale Medical School this past May. Congratulations. And has gone on to start a 4-year residency program at NYU in emergency services, but is still very involved in the APT Foundation to everyone's benefit. And the highlights of her recent research about homelessness and opioid use disorder. Although they're both important public health issues, few studies have examined their co-occurrence. So you're going to hear today some highlights that concluded low barrier to treatment access programs can attract people who are homeless with opioid use disorder into methadone maintenance. And these programs also have an important public health role in addressing both depression and OUD among people who are homeless. And we also have with us today, I'm very thankful for that, Teresa Fabrizi-Alves, who works at Columbus House in Outreach Services, who will talk about the path that folks come through to get connected to services for both co-occurring things. Marina, introduce yourself and take it away with our presentation.
Thank you so much. It's such an honor to speak to all of you, and I'm excited to speak with you during the question and answer session after. I'm going to be speaking about some different research projects that we have been doing at APT on this question of the co-occurrence of homelessness and opioid use disorder. And I'll speak about why I think it's really important to better serve folks who are experiencing homelessness in opioid treatment, particularly methadone and other medications for opioid use disorder. I'll talk about some of the projects we're doing in this area. Just as Eleanor said, my name is Marina Gazzola. I'm a resident physician in the Department of Emergency Medicine at NYU Langone Health, as well as Bellevue Hospital Center in New York City. I have been doing research at APT for the last 5 years. I'm still very happy to be working there. So just some brief introduction, background, and many of you may be familiar with these things, but unfortunately overdose, the leading cause of death among people experiencing homelessness, and most overdoses in our country happen secondary to opioids. And opioid use disorder itself is also more common among folks experiencing homelessness, particularly compared to the general population. You know, the experience of experiencing homelessness can exacerbate opioid use. My patients talk to me about using substances to cope with the experience of having to sleep outside, not having a place to live, trauma that they have experienced that may have contributed to their housing situation. And it can be very hard to stop using a substance that is helping you stay warm at night or helping you, cope with a very difficult situation. However, there are many folks experiencing homelessness who also want to enter treatment for opioid use disorder. The best treatments that we have for opioid use disorder, and they work very well, are medications. You're all here, so you're probably familiar with these treatments, but they include methadone, Suboxone, and naltrexone. Suboxone is buprenorphine, naloxone. You might hear me call it buprenorphine. And these are the only opioid use disorder treatments that have been shown to really have any measurable benefit on a population level for main outcomes in opioid use disorder. So things like reducing substance use, leading to stopping using substances altogether, lowering the risk of infectious disease from use, as well as lowering all-cause and overdose mortality. And unfortunately, most people with opioid use disorder do not receive these treatments, even if they do take the really big step of entering treatment. Not all treatment facilities offer these treatments, even though they have the best evidence. And unfortunately, there is actually a disparity based on housing status. So among people experiencing homelessness compared to those who are housed, when they even go to enter treatment for opioid use disorder are less likely to be offered these medications that are life-saving. There has been a lot of research on the topic of retention, or how long people stay in these medications for opioid use disorder. Just nationally for all patients, people generally tend to stay less than 6 months. However, there are these benefits that I've already talked about really still exist almost regardless of how long people stay. Obviously, the degree of the benefit is greater if you stay in treatment longer, but even being in treatment for a month can make a difference for patients. And it's perfectly reasonable that a patient might, enter treatment several times before staying in treatment a long time. That's sort of sometimes the natural course for some folks in these treatments. Prior studies that look at retention, or how long people stay in treatment, have looked at many different factors to try to see what is related to how long people stay. And some of these studies have used homelessness. And so there's sort of this sense that maybe housing status is related to how long people stay in treatment. But there really are very few studies that say, I would like to compare a group of people who are experiencing homelessness to a group of people who are housed, and look at what are the differences between these two groups and how long they stay in methadone treatment, or do they complete methadone treatment. And so that was the gap that actually a second, third year medical student that I and Dr. Berry, the head of research at APT, identified, and that we have been trying to fill with some of the studies we've been doing at APT. For all the reasons I mentioned before, it's really urgent that we attract and keep these folks experiencing homelessness in these evidence-based life-saving medications because of the high risk of overdose. But for some reason, no one is really studying this. If we don't know what the differences are, we don't know how we can maybe begin to address them. And I think, to me, that it feels really urgent to address these disparities. And one thing that makes APT a really good fit for studying homelessness and outcomes and medications for opioid use disorder is that as a program, we have a philosophy that reduces restrictions to treatment. We really don't do administrative discharges, which are where the program removes a patient from treatment prematurely due to maybe not following a policy, or being late to an appointment, or having a positive urine drug screen, which is true of many methadone clinics nationally. And so this allows us to really study whether patients are staying in treatment sort of their own accord, not if the program is kicking people out. So with that in mind, we have two studies that I'll talk about today, and then one that we are actually actively recruiting for. So the first study, which was published in a journal called Medical Care, I realized in my presentation, both of the two studies I'll talk about today have actually been published in peer-reviewed journals. And so I'll share the links in the chat later if anyone wants to read the papers. But this first study was really surprisingly one of the first studies to say, let's look at people who are experiencing homelessness to those who are housed in methadone treatment to try to see if there are any differences in anything for these two groups other than their housing status. And so we sought to do this, and our objective was to evaluate the characteristics associated with homelessness among patients at APT. So the way we did this is part of a larger study where we recruited patients at APT with flyers. The people interested in participating met with a research assistant and filled out a number of surveys that included things like demographic information, substance use related characteristics, so things like their age at first opioid use, or age of opioid addiction, treatment characteristics, for example, the number of months they've been in methadone treatment, or the dose of methadone, and then some measures of depression as well. And our main research question was, are there differences in these demographics, these clinical characteristics, and treatment characteristics when we're comparing the group of patients who are experiencing homelessness to those who are housed? So here are some of our results. Just at baseline, this is for the whole group of patients. We found that most patients were male, but 41% were female, 41% were non-white, with 11% being Latinx. The mean age of regular opioid use was 24, and the mean age of opioid addiction was 25 years. And in terms of treatment, the average amount of number of months that people stay in treatment was 41 months. So the folks in this study had really been in treatment a long time. And the mean number of non-Sunday take-home doses was 1. So most folks didn't have extra take-homes. The mean methadone dose was 80 milligrams, which is like a good standard dose. When we looked at all the patients, 164, our sample was 164, 39 were currently experiencing homelessness, and 125 were housed. So any differences that I report will be between those two groups. However, in general, our folks had a lot of experience with homelessness. While only 24% in this study were currently experiencing homelessness, 68% reported ever having an episode of homelessness. And so when we compared our patients, the only main differences that emerged were that those who were experiencing homelessness were more likely to be male and had higher depressive symptoms, but there really weren't any differences in those treatment-related characteristics. They didn't have different methadone doses. They actually didn't really have a difference in length of treatment, which was a reassuring finding. And, to me, the sort of main findings for this study that people were most interested in were that we had a high percentage of patients who are both experiencing homelessness, yet were in long-term methadone treatment. So that means there's a group of folks who, despite all the barriers that they might face with their housing status, do stay in treatment. And in this group, their mean duration of treatment was greater than 2 years, which is much higher than that average of less than 6 months nationally that I talked about earlier. And so what does this mean? This means that we as a methadone provider are an important connection to the healthcare system for people with opioid use disorder who are experiencing homelessness. For better or for worse, patients come to us, especially in their first 90 days, every single day or 6 days a week. And so that means that there is a lot of opportunity for us to address the difficulties that patients experiencing homelessness may face in our treatment setting, and that it is really encouraging and exciting that there is a group of patients who stay in methadone treatment long-term, despite all the barriers that they might face with transportation and travel and other things in light of them experiencing homelessness. And that there is a lot we probably can learn from these patients, and I'll talk more about how we're going to be doing that in a couple slides. So then our next study, we wanted to expand on this first study to look at more long-term data. And so if we're looking at a group of patients that starts treatment at the same time, which is not the case in that first study, what are treatment outcomes 1 year later? And we also similarly looked at patient characteristics based on those two groups of homelessness versus housed. This time, we also looked at a much more expanded group of patient characteristics. So this is sort of a bigger and longer term study. So this is very quickly just what we did. We did a retrospective medical chart review, which just means 1 year after patients enrolled, we then looked back to get the data using just their medical record. Our sample was all patients who were enrolled. So just every single one at APT from April to October 2017. And the things that we looked at were just part of the regular APT intake. So we weren't asking patients to do anything extra for this study. We just used the data that we have naturally in the medical record. And this includes measures of their sociodemographics, things like psychological distress, trauma, smoking history, and chronic pain history. And we had 2 research questions this time. The first was when we are comparing the group of patients who are experiencing homelessness to those who are housed, this time at treatment enrollment. Is there a difference in their demographics, their clinical characteristics, and their treatment characteristics? And then we also wanted to know, are there differences in the length of time that these folks have in treatment? So here are our results. From April to October 2017, APT enrolled 488 patients. Of those, 46 were experiencing homelessness and 442 were housed. And we found that, unfortunately, the patients experiencing homelessness had lower social support, lower recent employment opportunities, higher levels of psychological distress, higher levels of physical and sexual assault, higher rates of recent cannabis use, and higher rates of current chronic pain. And when we looked at retention, so this is just a slide that sort of plots over time whether folks stayed in treatment or not. So this is a percentage or a proportion of all the patients in the sample. And this is the number of days they stayed in treatment. And then the sort of solid line are the group who are housed. And then the dotted line is the group experiencing homelessness. And you can just see, looking at this graph that at almost every stage, the group who were housed at treatment enrollment had a higher proportion stay in treatment than the group who were experiencing homelessness. And putting it into numeric terms, homelessness was associated with a 69% increase in stopping treatment within 1 year. This is an unfortunate finding and something that I'll talk about what we're doing to work to improve. So what does this mean? So, This study found that unhoused patients entering methadone treatment have multiple potential vulnerabilities, trauma history, decreased social support, decreased access to employment, and other social determinants that we know can impact health. And we also found that when we, I should have mentioned, but when this statistic, 69% increase in stopping treatment, this is after we account for all of the other factors. So it wouldn't matter that some people were employed and some weren't. We accounted for that, or we accounted for trauma, we accounted for psychological distress, and this was still the outcome that we had. And so it was really the housing status that made a difference, and many of those other factors were not significantly related to how long people stayed in treatment, which was honestly surprising. So the conclusion of this is that homelessness is an independent risk factor. It's something about that housing status or something else we didn't account for in our study that was the risk factor for stopping treatment early. And this is in APT, which we know reduces a lot of the common barriers to methadone treatment, isn't necessarily true nationally. And so to me, this says, we should be identifying and addressing these vulnerabilities when people enroll in methadone. And the hope would be that if we try to address these things and the barriers that folks face, maybe that will help them stay in treatment longer and improve their quality of life and their experience in treatment. Where do we go from here? I think that last study was really sobering for all of us who did the study, because there's so much we could do. We want to do more for our patients who are experiencing homelessness to help them stay in treatment. The group that were housed and the average retention in treatment at APT is very similar to the national averages, despite our low barrier model. And so generally patients stay in APT for a very long time and do very well in treatment. And so we want to do more for our clients who are experiencing homelessness. And so we're now in the middle of a new study. We're just about to start recruiting patients, where we're really looking at the experiences and perspectives of APT patients who have experienced homelessness while receiving methadone treatment, both either at APT or at another facility. We're looking to recruit 50 patients, and we're going to do what's called mixed methods. So we'll do some surveys that will analyze quantitatively, but then we're also going to do long interviews with the clients to learn how APT can better serve the needs of our clients experiencing homelessness, because we really want to hear their suggestions of what we can do different in order to help improve their experience in treatment and hopefully the length of time they stay in treatment. So thank you so much for listening. I really appreciate any questions you might have. And if you want to know more about any of these things, please feel free to reach out to me. Here's my email and my Twitter. Thank you so much.
Thank you so much, Marina. So you're saying that homelessness is an independent variable. Addressing the homeless housing status would scientifically, based on your findings, automatically lengthen the time that people stay in treatment?
That's a great question. I think it was an association, not a cause. It was a correlation, not a causation. So we can't say that it was the homelessness itself that led to it, but I think all folks who are involved in this space who, take care of people experiencing homelessness would say that the solution to homelessness is housing, and would advocate for broadening of housing opportunities, permanent supportive housing, or other very well research-backed methods that end homelessness and help folks who are experiencing homelessness who may have complex medical or other conditions stay and thrive while housed. So, I don't know that APT would be able to provide housing for these folks, but what we're hoping to do with this new study is to say, what are things we could do? Could we provide better care coordination? Is transportation perhaps an issue? Because that was not something we looked at in the study. Is having access to a phone or a computer where you can talk to your case manager? Are those things? It's having like a food bank at APT. Like, what are things that we could feasibly do at APT that would maybe help facilitate clients who are in the housing process or want to be in the housing process, or just generally would make the experience at APT more conducive to the needs of these folks? That's sort of what we're hoping to do with this study.
Gotcha. That's very interesting. And we're going to get real basic now and just ask, how do you actually define homelessness?
In the two studies, it was the same measure, which is helpful, which is a questionnaire just asks about where the patient spent the night in the last 30 days. There are a number of options. It's from this survey called the Basis 24, which we use in a lot of our research to try to standardize the way we ask these questions. But unfortunately, you bring up a good point, because in a lot of research on homelessness is perhaps defined differently, and that can also complicate things. So we focus on past 30 days, because often folks experiencing homelessness might be in the hospital for the last 7 days or something like that. So we try to have enough of a period to sort of demonstrate a pattern.
That makes sense. Thanks. Maybe this would be a good time to bring Teresa into the conversation. Curious to hear how Columbus House defines homelessness, Teresa.
Well, hello. It's not specifically Columbus House. It's HUD's definition of homelessness, of being unsheltered. So our criteria to work with clients that are actually homeless, they have to be living in a unsheltered, whether it be not on somebody's couch. Couch surfing draws a fine line, especially with a lot of my females dealing with DV that are sex workers. But the definition of homelessness is if you stay on somebody's couch over 6 days, you're considered housed. Jail is considered housed because you have meals and a place to sleep. So yeah, you have to be unsheltered, and whether, living in a car, tents, and also shelters are included.
Gotcha. You want to talk about your kind of day-to-day responsibilities as an outreach specialist and the kinds of conditions that you encounter, this overlap?
I started out as I'm a recovery coach at Columbus House, and my criteria for my program is an opioid. At first was opioid substance abuse disorder. Yeah, I connect with people. I do a street outreach. I also sometimes I'll get referrals from the CAN, which is 211 United Way, when people call in asking for shelter, and then if they want case management, I might try to connect with them. But yeah, I mostly connect with the really, really hard clients that it seems like other case managers maybe they have a hard time connecting with. These are the clients that don't show up for appointments. Having lived this experience, I feel benefits this role, because I understand the disease of addiction and how much it controls us, and when you're in the grips. So, a lot of clients don't, miss appointments. So I go out and visit them at their sites, and then, I'll get them connected to, mental health services. And I think you spoke about transportation. I will pick up a client and take them to appointments. Also, there's free buses. In New Haven, also with food, you'll never go hungry. There's many, many soup kitchens, many, many providers. Yeah. So yeah, I've tried to form a bond with my clients and build a trust. We work on the housing first model. I try to get my clients connected with substance abuse and mental health. I lost a couple of clients this year after I housed them from ODs.
You're saying housing first means addressing the housing status.
First. Oh yeah, putting
prior.
Housing a client first, and then addressing their needs after.
And is that the standard of care, or?
That is, yeah. Myself, I try to work with the client a little bit longer before I try to, I match them to housing. If they're really, really deep in their addiction, and try to get them connected to substance abuse first.
Maybe now's a good chance just to see if listening to each other has brought up any curiosities or questions that Marina would have for Teresa, or vice versa. And we'll start there and then broaden the Q&A. Any curiosities people have, let's see them in the chat, and we'll make sure they get addressed.
As a matter of fact, I just have a new coworker that she's new with Columbus House, and I invite her into this forum because she's also a recovery support specialist, and she's working with our clients that are out there in need.
Oh, great. So she's in the room with us now?
She is. Hi, Beth.
Hi, everybody. Thank you for having me.
Wonderful. Thanks, Adam, for your comment here in the chat.
I work with clients, first thing I try to see if they want to get into a treatment program. I utilize addiction services so much. And And we also have road recovery at Columbus House. So, I try to get clients connected to detox and rehab. And a lot of my clients utilize the App Foundation inpatient program because they could stay there to 89 days. The 90th day, they're considered housed. So I try to work that into their treatment plan, before they get housed, to do an inpatient program and they could transition into housing. That's the perfect picture. Doesn't always happen like that. There's always barriers. Yeah, that's what I try to help the clients with.
Cool. You say there's always barriers. Do you want to talk about a couple of them that you tend to see, like kind of pitfalls, and how you try to work around them or work with them?
Oh, well, no, the barriers being the system. And, sometimes it's not, I'm talking about like a bed opening up and the client not being ready, or the bed falling through, or just, discharge date. Sometimes it just doesn't always align. Like I try to maybe get them into treatment to go to enter their housing, because the clients have to be chronic for 1 full year. If somebody has income, then I could get them connected to like rapid rehousing so they could sustain their housing maybe a year or two after. But a lot of my clients with opioid disorder, they're not working. So we need to try to get some income. If not, they have to be chronic for 1 full year of homelessness before they get matched to a subsidy. So it's time consuming also.
Mm-hmm. Now, question in the chat here. Thank you, Angela. Can someone just go to Columbus House for outreach services without a referral, or they have to go through 211, or what's the path?
Oh, absolutely. They could just come in and ask they want to get connected to case management services, and we'll get the process going.
Mm-hmm, mm-hmm.
We just oversee the shelters. That's another thing. Like, people think that if they come into Columbus House, they could get into shelter. They have to call 211 first. And then,
Okay. So that's where the 211 comes in.
correct. And now all of our warming centers have opened. I'll send that to you if you like. Our
Yes.
overflow has opened up. There's 266 State Street desk. There's the O'Keefe Center in Hamden, and 2 churches, if I'm not mistaken, in New Haven that will be doing warming centers.
Mm-hmm. So regarding Adam's comment about how people spend their free time, do you provide any guidance or recommendations about that?
During the day, yeah, I send my clients down to Fellowship Place on Elm Street. They have a day program. Also Safe Haven on State Street has a day program. And also now for Fairhaven area, Hispanic population, they're going to be opening up a drop-in center. This is something new that's coming about for Fairhaven, which is desperately needed.
And Marina, do you want to talk about the App Foundation's groups?
Yeah.
Because my understanding is that clients can select from a menu of whatever groups they feel like dropping in to that day. And
Yes, I was actually going to say that, after we have sort of like, so there's a mandatory counseling requirement, which is a national regulation for people to be enrolled in methadone treatment. They have to meet a certain number of counseling hours per month. And this can be restrictive in general if people have to make like a certain appointment at a certain time, and that's challenging. At APT, we've liberalized the requirement, but it still meets the federal guidelines by having groups that people can just drop into whenever is convenient to them and whatever topic is interesting to them. There's no limit on how many or groups you can go to as long as you're meeting your minimum requirement. And so that's actually one of the questions that we have in our study for clients is like, would it be helpful to have a group on this topic? Would it be helpful, whereas groups are the way we meet the counseling requirement, would it actually be more helpful for you to meet your counseling requirement by meeting with a psychiatrist or a psychologist or a counselor every month? You tell us what would maybe better serve your needs. So these are some of the things we're interested in, because in theory, if someone came and wanted to go spend their day going to multiple groups, that would be totally possible. And we do have groups that range from things like talking about chronic pain to, more sort of like traditional therapy and substance use focused groups, and can meet people's varied needs.
great. So I'll drop that into the chat too shortly. Now, Adam, you mentioned desk. Do you want to come off mute and talk about what that is, and also the types of programs that you offer?
Hi, everybody. Thank you so much for this. This has been really informative. Marina, thank you. So yeah, Desk, I can't speak at length about it, but it's downtown evening soup kitchen. They've recently got a new location on State Street, just a block away from Safe Haven. And they are a drop-in center to just come in as you are, get a hot cup of coffee. Yeah, so that's really good. That's recently opened in the last year. And some of that was based on discussions that we've had with my program called Musical Intervention. Musical Intervention has been downtown for 7 years. We open up our doors to anybody who wants to come in to create, mainly create music, community art. It's been a really amazing experience, built off a lot of the work that I've done in research with music and science, as well as being a recreation therapist in an inpatient psychiatric hospital for many years. And so one thing I was thinking, in this presentation, a lot of people that are experiencing homelessness have a lot of free time on their hands. And that's a very important element in their life. And so you had mentioned in the study that a lot of these people are using to maintain their sanity, or you said staying, doing things to stay warm, or whatever the case, whatever it takes, right, to survive the experience. And that changes day to day, moment to moment for people that are living for the moment, right? So yeah, so as far as places for people to go that they can be around in healthy communities, things like that, it's often overlooked in research. What do people do with the majority of their day? I'm wondering if you've thought at all about this in this new research project. I know you've already quite a bit down the road with it, and you're getting started. Also, on a side note, we are excited to help recruit if you're looking for people.
Good to know, Adam,
That's
that
a
you're
good point.
open. I didn't know that you're back open over there.
Yeah, so we were on Crown Street temporarily while they were doing construction here for the past year, and
Okay.
actually this next Friday, the 9th, December 9th, we're having a grand reopening celebration, and we should have a nice turnout and share some of the really cool stories that we've had.
Adam, can you drop your contact info? I started working with a client. You might know him. He is so musically talented. And yeah, I think he would benefit from your place so much.
I would also like to say I worked with the App Foundation for 8 years, going into inpatient services with our mobile recording setup, and it really was some of the best years. I have an incredible playlist online from some of the folks we worked with.
I bet you do.
Yeah, the
I'd love to
recorded
hear that.
music is an asset, and that's a resource that that people in the house in this community should know about. That beautiful storehouse of recorded music, songs written by people with lived experience out of the App Foundation. So thanks for mentioning that.
Because that's also one important piece of my intake that I do with speak with clients of, their talents, their gifts, that what they love to do. And it's such a gift to do, like talk about a year later after to introduce them back to what they used to love to do, so music is very a lot of clients relate to music.
I mean, we've been open for 7 years downtown, and you wouldn't believe the talent when they get an opportunity to express themselves. And that gap of housing is crazy. I mean, it takes so long for some people. And what do you do with the meantime, right? How do you?
Correct, right? What do you do in the meantime? Thank God for the drop-in centers. 266 opened up during the pandemic. But yeah, there's not a lot of places for clients to go.
Yeah, we do have some research with Yale to support retention and the power of identity. And one of the things was something that I've noticed was people engaged in our program do often stay in contact with their treatment plan.
Thank you, Adam.
Yeah.
Marina, is help with recruiting something that the App Foundation is looking for to partner with community organizations to get people into the new study?
Oh, yeah. I mean, I think we're always very interested in making sure that we have like a broad and accurate reach of the population that we're trying to do the study with. and so I definitely, Adam, we should connect after this, because they can think of a lot of things that we could talk about. And one thing in response to your question about have we thought about like leisure time and how people spend their time, it's, in a number of our studies, not necessarily this one specifically, but Dr. Berry, who's the head of research at APT, who I work with, one of the studies on, he's like a large study looking at chronic pain and opioid use disorder. And, one of the things that we talk with clients a lot about is meaningful activities that can help patients distract from pain and cravings and things like that. So it's definitely something that is, I think, very important to this work, because when you're suffering for whatever reason, it might be from opioid use disorder, from pain, or from a really difficult social situation, having meaningful ways to spend your time and express your talent and just, enriching your own life and fulfilling yourself are also important. So I'm glad you brought that up, but we should connect about this. And I think it'd be great, if there are APT clients who are using your services and have these experiences, I think that would bring a really unique perspective to the study. So would definitely be interested. Yes, there is excitement. Yeah, all of the I didn't mention it, but all of the studies we ever do at APT are always compensated. And we also, in this study, we also will be having like some coffee and snacks for people when they come in as well, just thinking about, making sure that when we're taking up people's time, that we're also making sure it's a comfortable environment for them.
From what I've heard from Lynn Madden, the CEO and president of the APT Foundation, is that people can, hook up to internet, use Facebook, pull up, get some water, something hot or cold beverage of their choice, and kind of relax in the access center until it's time to be seen. And so that's supportive. So there's a webinar that has come to my attention on this topic that I'm just going to drop in, that's happening tomorrow. There's a couple of overlapping groups in this room, and one is called Pro-Social, which is kind of an international problem-solving, practical kind of think tank. And tomorrow's topic in their webinar series is on homelessness. So there we go. There it is in the chat for everyone. Gavin, did you want to say anything about the webinar series and how that came to your attention? I know you've gotten a lot of value out of them, or about this topic in general. Gavin Watson, who's in our room today, is board chair of Conscious Capitalism of Connecticut. Go ahead.
Sorry. Yeah, I was working on cooking some stuff in the background while I was listening. But the pro-social group is really good. It's based on the research of David Sloan Wilson, who's an evolutionary biologist, and it's about essentially the idea that altruistic groups outperform selfish groups. So if you can build an altruistic group, it'll be more successful. And this is and he's been having these seminars or whatever webinars with different guests, and almost every single one that I've attended has been really, really good. So I expect this one will be very good also. So thanks for sharing.
I suppose an example of an altruistic group would be one that really looks out for its folks and makes sure that people don't get into these, horrible overlapping epidemic situations.
Yep, exactly. Yep. Yeah.
As we come up to the top of the hour, I'm wondering if anyone might have something else on their mind that maybe doesn't feel like it's fitting into the exact flow of the conversation, or you're not sure if you could bring it up. Just a warm encouragement that the flow is whoever we have here, and we really believe that whoever shows up are the right people to have a conversation that's not going to happen in exactly this way at any other point in time. So we want to take full advantage.
So I just want to say hi, Marina. Finally, to see you in this platform. Actually, we haven't met. We've been emailing back and forth a lot regarding your next research or the program. So this is fantastic. I'm very, very glad to have seen the results for these previous studies. And like I mentioned, they connect a lot of dots for me because, you know, my role is technical, not clinical or medical by any means. But nevertheless, I'm very curious about the work that we do here, obviously, the research that is going on, and it's excellent. One of the things that I noticed, like that there are many reported like the connections between like homelessness and overdose, and being like the amount of free time that people have, and the complaints that we get from the city of New Haven. All these things kind of connect together. It's just like, oh yes, that's what's going on. And this was actually the timing of the research was exactly the timing of when we were having these issues. I wish we had.
Well, Beth, it's so great that you were able to come along for the ride here. Any thoughts or
Oh, no, I just
surprises
sounded very,
that you'd like to share?
oh, I just sounded very informative and grateful to be here.
Well, we're glad to have you. And seems like even just in this hour, there's some follow-up that can be very practical and enriching to the research. And that New Haven, once again, is a place for you know, some big conversations, and ability to really impact people's lives. So I want to thank everyone who pushed out of the way whatever else they had on their desk to be here. And I'm sure we've got back-to-back meetings, so we might be able to give you a few minutes of your life back. Marina, Teresa, any parting words?
No, I just want to say thank you so much for coming. Please feel free to reach out if you have any questions or want to connect about any of these issues. I think all of us at APT are really motivated to, you know, we love our patients, we care so much, and this particular group of patients, I think we just feel a lot of urgency about, you know, keeping them in treatment just because of the fentanyl crisis and the worsening overdose crisis. And so if there's anything, if there's anything that, you know, we could collaborate on, or, you know, any ideas you have, I'd love to hear it, because, you know, we should all work together on helping, as you say, keep our patients alive.
Great. And so if there's you know, any art and wellness fairs, you know, that are coming up, it seems like, you know, almost all of you all would have some kind of contribution to a public facing event that aims to get people, you know, it's so mainstream now that people know people who are struggling in every single town and walk of life, and just need to keep this information flowing so that it gets in the right hands, right? Teresa, how can people contact you, or should they, if they have any
Yeah,
follow-up
I was gonna
questions?
say I would have dropped my contact info. You could also pass it on, but I'll put it in the chat. And I just want to say thank you for having me. This is great. You know, any resources, anything, any connections, any bridges, to connect to, people that are in need. Yeah. And thank you, Adam, for that.
Open mic is tonight
yeah.
down at 23 Temple Street, open mic
Open
at
mic.
Musical Intervention.
I'm going to definitely stop by there during outreach, Adam, and I'll pass the word on to our outreach team.
That's great. I'm glad to have you back here, and super excited for the 9th, if anybody can make it and support this thing. And, you know, I love more of these meetings. Anytime we get together and collaborate, it's so important to have, you know, an interdisciplinary team approach this. So
Absolutely.
I'd like to see a couple more lived experience, you know, I mean, not more lived experience, but more, you know, participants in it. So
Yeah, 360 degrees, looking at things from all different angles. It's really, really great to hear. So
I just
thanks
wanted
for
to,
all the,
I just wanted to say,
please.
because I think I'm a little bit newer to this, probably this forum and this group, but I could be a resource to you guys as well. So my agency is called Guardian Ad Litem Services, Melissa's Project. And we do care coordination for clients who have conservators and who are involved with DEMAS. So we do get a lot of co-occurring clients. We do a lot of work with the App Foundation as well. So if there was any concerns or questions about conservatorships or conserved clients, you definitely can reach out to me. And Adam will definitely be swinging some people your way. In Columbus House, we always work with you guys as well. So it was really nice to meet everybody.
Thank you, Angela, and thank you for keeping the conversation going with your questions. And please put your contact information into the chat. I honestly could use it, put that right in my Rolodex. There are people who get stuck in very interesting conservator situations and might need a little help to get unstuck. Thank you.
Absolutely. Thank you.
One really quick.
Sure.
For our research project. So we have a research project for voice hearers, people who have auditory hallucinations, typically with a diagnosis of schizophrenia, but we've been able to expand a little bit. We're in our second phase. And so if anybody knows anyone who suffers with auditory hallucinations, finds it distressing, can reach out to me or the Belief Lab at Yale University. It's an NIH grant, and it's been really, really great so far. So,
Oh God, I got a perfect client for you. I'm totally going to be calling you after this.
and we could
It'll
use
be so good.
very difficult recruitment.
Hmm.
We could use all the help we can get there.
I'll say I took a crack at some of the messaging, and when you're talking to creative people and you ask if they hear things that other people don't hear, they'll be like, yes, and so we had a little confusion. We had some people responding for different reasons. So it is a little tough to narrow down. So thank you, Angela, +1 in your column there. All right, at 2:57, I'm going to be ending the recording and the meeting, but not the conversation. This is just the beginning. So thank you so much.